Good morning. My name is Dr. Tracy McNamara. I'm the pathologist at the Wildlife Conservation Society, better known to you probably as the Bronx Zoo. And this morning we're going to be covering zoo pathology. We'll start out with an hour on a general introduction of what zoo pathology is, and then that'll be followed by 2 hours on the pathology of reptiles and amphibians. Before I get started, I'd first like to take the opportunity to thank the editors of the Journal of Zoo and Wildlife Medicine and the Journal of the American Veterinary Medical Association for giving me permission to use some of the title slides that you'll see this morning. I'd also like to thank the photography department of the Wildlife Conservation Society, as well as a professional photographer, Mr. Art Wolf, who provided many of the beautiful images you'll be seeing today to help us inspire people to care about wildlife. Okay, well, let's look at the first slides that you'll see this morning. So let's take a quick look at what makes zoo pathology special. Well, unlike other veterinary pathologists who often end up focusing on a limited number of species after training, such as lab animal or only dog and cat or maybe just avian, in the zoo field, we work not only with lions and tigers and bears, oh my, but also beautiful marine mammals, exotic birds, reptiles, and amphibians. Now this makes for very exciting work, but also very challenging, because as we all know, a lot of this material is not really covered in the routine veterinary curriculum. And if we're to apply the same criteria of excellence and competence to these exotic species as we routinely do to domestic species, we have a lot of work to do. We have to learn the specialized anatomy and physiology and histology of all these species. And in addition to sort of starting from scratch, the flip side of it is, since we are working with a zebra, we may have to pull on our knowledge of equine diseases. If we're working on a gaur, that's all our knowledge of bovine diseases. So although people tend to think of us as very specialized pathologists, in fact, on a daily basis, we have to pull out everything we learned in vet school and try to apply it to zoo animals. Now, if we're lucky, there will be some overlap in the disease problems, but then there's always that other thing, since this is such a frontier, we're always going to be looking at previously undescribed problems. So in a way, we're the ultimate generalists and the ultimate specialists. Now, on top of all that species variability in a zoo setting, the other thing that we have to deal with, a factor that is very important, is the very fact that we're dealing with animals in a zoo. This is not a controlled experimental setting. This is not a drug company. The animals we work with are not specific pathogen free. And in fact, you're going to see a lot of spontaneous infectious disease in any zoo setting. Now, look at this beautiful exhibit. It's certainly beneficial to the overall well-being of the animal, but it's going to introduce certain variables in terms of attempting to control an infectious disease outbreak, and those are all things you are going to need to address if you are reading out any zoo material. The other thing we have to deal with in a zoo is the fact that species often are not kept in single species groups. We may see animals that are kept together in a mixed species exhibit, such as these gelada baboons that are in with ibex, hoofstock. So we have to worry not only about disease being transmitted from one species to the same, but from one species to an entirely different one. The threat of disease introduction comes not only from in-house collection animals, but also from local indigenous wildlife found on the zoo grounds, such as swans or raccoons. This threat of introduced disease is a very serious one, especially in light of the fact that zoo animals are kept generally in herds or flocks. So if one animal gets sick, there's a terrific potential for rapid spread of disease through an entire group of animals. And so basically we're looking at a population of very rare and valuable animals at significant risk. And the other problem is, even though we may be aware of a problem or a disease threat in a zoo collection, we may not be able to actually address that. A lot of the vaccines that we take for granted as being used in domestic animals are not going to work in these non-domestic species. Given all these factors, I see the primary function of someone reading out zoo cases, or perhaps functioning as a full-time zoo pathologist, is that of providing rapid and accurate diagnostic service to the curatorial and veterinary staff of that zoo. That allows them to take the steps, the management changes that we might need to do to prevent further losses in the collection. And in that regard, I think pathologists can play a vital role in protecting and safeguarding the health of zoo animals. In fact, I can really think of no other area of veterinary medicine today where there's a more compelling need for pathology. The bottom line is, can we afford to lose an endangered species to an otherwise preventable disease simply because no one looked? Well, of course not. I think everyone's reaction is going to be, of course not. But if you stop and think about it, and we need to do that, what are we as a pathology community doing to try to meet the needs of the zoo field? Of the 176 accredited zoos in the United States, how many of you think actually have full-time pathology service? There are only 6 zoos with full-time pathology service: the National Zoo, the Philadelphia Zoo, the Wildlife Conservation Society, the San Diego Zoo, and more recently the University of Illinois program, where they're providing service for the Brookfield and Lincoln Park Zoo and the Shedd Aquarium. That's it. Well, what are the other zoos doing for pathology service? What's going on with them? Who's taking care of all of those animals? It's a very legitimate and valid question, and one we thought needed to be asked. So several years ago, the C.L. Davis Foundation did a survey of the American zoo population, and we asked them those questions. And the responses were disconcerting on 2 points. Many zoos in the U.S. really have limited pathology service at this moment, although I think many of them are attempting to raise the necessary budgets to incorporate this in their animal health program. The other part of this survey that was even more disturbing was the fact that of those zoos that are currently paying for path service, many of them are not very happy with the quality of service they're currently receiving. And the universal response was, well, I send tissues off and I get this letter back and it's a real long description of something seen under the microscope, and there may be some kind of morphologic diagnosis, but the bottom line is it's not very helpful, and I got the impression the guy who was reading the slides sort of signed him out as if it's a dog or a cat. Now, you know, that's a problem because, now granted, you know, I mean, this is a real problem. Let's stop and think about this. Because even though there is some overlap in the area of domestic animal pathology with that of zoo animals, we can't make these sweeping extrapolations from one species to the next. I mean, just because we might be comfortable, if you're working on a lot of dogs, you might look at the liver of this pen-tailed batong and say, well, oh, that's lymphoma. And if you're doing a lot of poultry, you might look at the liver of this white-naped crane and say, well, that's got to be Marek's disease or lymphoid leukosis, no problem. And the problem is you're able to come up with those differentials, that list of potential diseases you need to consider at the time of your necropsy, because you've studied all of those diseases in domestic animals. Now, doesn't it make sense that when you consider all of the species in the animal kingdom, that some of these animals might not also have their own unique set of problems, such as those seen in the dog or the cat or the cow or the horse or the pig or the sheep? I mean, the bottom line is, who better than a veterinary pathologist knows that white spots in the liver of one species do not necessarily equal white spots in the liver of another species. That's why everyone takes these board prep courses. That's why everyone spends 4 years in vet school and 3 years in residency. That's so we can be judged competent to diagnose disease in those species. So reasonably, if you're going to be working on zoo material, it goes without saying you're going to have to be doing some extra work to be able to generate that list of differentials. If you don't do that, I mean, some days you may dodge the bullet, you may get lucky, and in some cases, you know, even though you haven't really stopped to consider all of the potential differential diagnoses you must think of when you're working on this material, you may get off easy. If you're lucky, it may be something that we can pick up on histology. Now, that pen-tailed batong with a hepatitis, that was Capillaria hepatica. But honestly, how many people looking at that slide the first time I showed you the gross lesion were really even thinking of parasitic? In other cases, we may not be so lucky. And if you put on those intellectual blinders of assuming that every zoo case you work on is going to be something routine and within your frame of reference, unfortunately, you may not consider doing the kinds of procedures you need to do at the time of the necropsy to ensure a diagnosis. In fact, if you simply take some of that material and toss it in formalin, you may make it impossible to ever arrive at a diagnosis. That white-naped crane with the hepatitis, this was a previously undescribed disseminated coccidial infection known as Eimeria gruzi, and we were only able to arrive at that diagnosis by the fact that we actually had saved tissues for electron microscopy at the time of the post. But this is the bottom line is when you're working on this kind of stuff, if you want to be able to be assured of some level of success, make no assumptions. These animals are not dogs and cats or cows. You do need to consider all of the possible differentials, not just those you're comfortable with. You have to keep your diagnostic bridges open. Don't toss everything into formalin. Maybe you need to freeze tissues for mycobacterial or viral isolation. Maybe you need to do fungal cultures. Maybe we need to do impression smears, toxicology, you know, all of those things that we may not be doing on a day-to-day basis with well-vaccinated, healthy domestic animals. And of course, the key to being a successful diagnostic pathologist is knowing the literature. Now, I know this sounds like a difficult task, and I'm sure many of you, if you're preparing for boards or looking at this tape and you're asking yourself this question, how are we supposed to do this? Is this woman out of her mind? I mean, we have to read 10 major journals as it is just to be able to get through the domestic animal material. How are we supposed to take on everything in the wild animal kingdom as well? Well, to make things a little easier for you, in your handout, which is available on the C.L. Davis homepage on the web. On page 3, you have a nice list of general references on zoo and wildlife pathology or medicine. And bottom line, if you're charging a zoo for your services, if you're reading out a biopsy on some animal, and don't they have a right to expect you to know what kind of animal that is? I mean, that pintail batong that I showed you earlier, well, that's a marsupial. You know, you're going to know that by reading the basic books. On page 4 of the handout, I mention and describe a literature database called the Veterinary Librarian. This was a veterinary literature database created several years ago that we at the Bronx Zoo decided to invest in because it was the only one at the time that actually covered not only the domestic animal literature, which will be, you know, they cover veterinary pathology and JAVMA and, you know, the basic journals that we all have to read. But in addition to that, it also covers the Journal of Zoo and Wildlife Medicine, the Journal of Wildlife Diseases, and, this is unique, the proceedings from all of the annual zoo meetings. And there is buried treasure in some of those conference proceedings. So we find this very helpful. It's updated every 6 months. It's very inexpensive. And I'd recommend to all of you that you consider investing in this, because when you go to do your first zoo case, you just sit down at the database, you pull up a listing for that given species, and you have some idea of what's been described in that group of animals. Another thing you might want to consider is the, don't limit yourself to doing literature searches within the United States. There's a wealth of literature across the ocean in Europe, and in Holland at the University of Utrecht, they have an excellent university database which has compiled citations on wildlife from schools all over Europe. And I believe it's only around $200, and it's an excellent investment. Another thing I hope anyone in the field of comparative pathology is already familiar with would be the video disc from the University of Georgia known as Noah's Archive. This teaching material has thousands of Kodachrome images on the diseases of not only domestic animals, but approximately 38 pages of citations on zoo and wildlife as well. And at the very end of the handout, I've printed out all of the available reptile accessions from the video disc. And so as you're going through this tape, if you wish to see some of these images again, just go to the video disc and punch the numbers in, and you'll be able to see those slides all over again. Okay, well, you know, if you do some of these things, you'll have your hands on the literature, you'll be able to look at the gross lesions, but you also have a lot of the histopathology at your fingertips. The Wednesday glass slide conference from the Armed Forces Institute of Pathology is on a database, and they have a tremendous wealth of exotic material that's been spread out over 40 years. And I've provided you on page 53 and 54 with a listing of the reptile accessions, but certainly you could simply go through their database and pull up all of the zoo material and look at those slides as well. Now, if you do all of those things, you'll really be well on your way to providing solid service for your zoo clients. But there's still one more factor that you need to put into this equation. When you arrive at a diagnosis on a zoo case, that's only the beginning of your job. A morphologic diagnosis really doesn't tell people what to do. And it's really, these cases demand that you take an epidemiologic approach. Once you have the diagnosis, you have to ask yourself a bunch of questions. How did this disease get into the collection? What's its mode of transmission? Is it aerosol? Is it enteric? Are we looking at a contaminated food or water supply? Is it hematogenous? Is this spread through an animal or an insect bite or through scratches? Is there a vector involved? If so, what's the life cycle of that vector? Because only in knowing that cycle will we be able to interrupt it. And let's not forget that the human component of this equation. If you're working with zoo material, those animals are kept by zookeepers, and there very well may be a zoonotic hazard that you need to inform the zoo staff of when you sign out some infectious disease case. Now, only in answering all these questions and providing a zoo with the information they need will you be able to help them arrest a current disease outbreak and prevent future outbreaks through management changes in the future. Obviously, these animals deserve the best care we can give them. As a group, as veterinary pathologists, we're in a position to do great good on their behalf, and frankly, if we don't do it, I don't know who else will. But once and for all, I think we need to get away from an unspoken but very real double standard of that I think is very predominates in the area of veterinary pathology, and that's of providing one level of care for domestic species and another for exotics. And the bottom line, even though you know, this may not be emphasized on the ACVP boards, and it may not currently be emphasized in the veterinary curriculum, we're all veterinarians, and when we take that oath to be a veterinarian, there's nothing in there about only taking care of the ones that are real easy. So you know, just keep these little words in mind, and then I'm sure everyone will do a very good job. Okay, well, that having been said, let's take a look at a few cases which are going to illustrate the principles. Now, you are probably familiar with many of the diseases we're going to discuss, but as you'll see, I think when you're working on zoo cases, there's often a slightly different twist to the presentation of that disease. All right, well, let's say you're working at a local zoo, and you do a necropsy on a duck, and you see that there are multifocal areas of hemorrhage in the liver. And you're concerned that this could be something quite serious. It could be any number of things, but you're going to try and address this. Now, you're not going to simply toss this in formalin and forget about it for a few weeks until the tissues are fixed and you've gotten them processed, right? No, wrong. You're not going to do that. You know, because if you take that epidemiologic approach, you know that these ducks came off of this pond. And again, taking that epidemiologic approach, since you've been discussing the collection with the curators and with the veterinary staff, and you're familiar with the settings and the exhibits these animals are coming from, you know that they plan to release 80 birds from quarantine from the hospital onto that very pond. And so because of that, you're going to do your job, and you're going to take a worst case scenario approach. You're going to say, I could be wrong, but I think this could be something very serious. And so you're going to speak to the curators and say, you know what, can you please hold off on releasing those birds overnight? Just let me get one stat slide, and when I get that piece of liver in the morning, I may have my answer, and let's just hold off on doing anything until then. So you do your stat histology, and lo and behold, on your slide, you see a beautiful intranuclear inclusion in the hepatocyte. We couple that with the fact that when you go through your mind, well, what are some of the things that can cause intranuclear inclusions? And certainly this looks fairly consistent with a possible herpes infection. And the bird also had these classic annular band necrosis, which is exactly as seen in the Diseases of Poultry, 9th edition, page 614. And armed with all that information, you are probably on pretty safe ground to say, I think we're dealing with a case of duck viral enteritis. And this is otherwise known as duck plague. For good reason, because this is a potentially devastating disease problem. And when this occurs in a zoo setting, it could easily wipe out the entire waterfowl collection of a zoo. This is one of those cases where simply signing out a morphologic diagnosis is not going to be enough. As a pathologist, you have to raise a red flag and set off all the alarms. Because if you don't, we could end up with a situation as occurred in Lake Andes in 1973, where a total of 43,000 ducks and geese died over a 2-month period. This can be a devastating disease. At the time when we had our outbreaks at the Bronx Zoo, at that point it was still considered a reportable disease. At this stage, I think they've backed off on that a little bit because there's very little we can do to control it in the wild animal population. However, it is still a disease which can have a serious economic importance. And when it occurred in Long Island in 1967, it essentially wiped out the Long Island duckling industry. Duck viral enteritis is caused by a herpes virus, which affects birds in the order Anseriformes, which includes your ducks, geese, and swans. Clinical signs are non-specific. This is not something that a zoo clinician is going to be able to diagnose. And unfortunately, the gross lesions can be rather variable as well. The histo is what's all important here, and you're going to see when you get your slide acute coagulative necrosis, and if you were to look in the periphery of any of these necrotic areas, chances are very good you would find beautiful eosinophilic intranuclear inclusion bodies. Now the problem we run into in a zoo setting, because this is that the fact that this disease has a variable incubation period and that there is varying species susceptibility to this disease. Some species of ducks are more resistant to the lethal effects of the virus, and they're considered carriers, and such as the mallard. We know that the virus can be spread by varying routes of transmission. What we're most concerned about in a regular setting is that some wild birds are going to come in, they'll succumb to the virus, and in the process of doing so, they'll greatly contaminate the pond in the zoo. That could be a huge problem because what people don't realize is many zoos have large, bodies of water with their own waterfowl collections on them, and we have feeding stations. And so during peak migratory periods, all this migratory waterfowl is going to come in for a free lunch. And it's very difficult to prevent these birds from introducing disease to the zoo birds. So what are we going to do? Well, you may say, if it's a single duck, it's no big deal, but again, like I said, if we have a large collection, this can be a very serious problem. In many ways, our hands are tied. In some cases, it's impossible to prevent these birds from coming into contact with the zoo birds unless you go to terrific expense, as was done at the North Carolina State Zoo, where they put huge nets to cover the waterfowl ponds, and they're essentially large aviaries now. We can't really eradicate the wild birds because you need permits to euthanize Canada geese, and it's just not a very viable option. Vaccination isn't very practical. This is a herpes virus. Even though a vaccine is available, the immunity is quite short-lived, and it's really too risky and impractical to consider vaccinating all the waterfowl in a zoo every 6 months. But what you can do is do the stat slide to pick up the index case. And these viruses are fragile. They aren't going to persist in the environment for very long. And if you can pick up a few of those early cases and then affect those management changes, like I said, and get your birds off the ponds or do whatever is necessary to keep them from coming in contact with this, you can wait until the worst is over and save a large number of birds. At our zoo, we go on a seasonal duck viral enteritis alert, And we remind our curators at weekly meetings of the importance of constant vigilance. And we tell the keepers to get any sick birds that are noted off of the ponds immediately. In fact, we make this part of our keeper training course. And you may also want to consider using sentinel species. We know that some birds are more susceptible to this virus. Well, you might want to keep some of them in your children's zoo, and they would be the first ones to succumb, and they will give you your first warning. Okay, well, let's take a look at another case. Red panda, lovely little animal, died at our Central Park Zoo, and the animal presented with massive hemorrhage, massive pulmonary hemorrhage. There's severe icterus, ecchymoses on the surface of the intestines. The liver also does not look terrific to me. It looks swollen and a little discolored, and so you have to consider, well, what are my possible differentials? This is obviously something very hot. What do I need to be thinking of? Well, the first thing you have to answer is, what is a red panda? I mean, what kind of animal is it? How do you even generate that list of differentials? Well, in fact, a red panda is a procyanid, and the taxonomic classification of this animal is actually a little controversial, but for our purposes, it's still called a procyanid. We know that they are susceptible to both canine and feline diseases. Well, I see one disease on that list that would give me cause for concern: infectious canine hepatitis, which could cause similar lesions, and there are indeed many unvaccinated dogs in New York City, so it's a reasonable differential. You look at your liver slides, however, and there are no intranuclear inclusions of the typical adenoviral infection of canine infectious hepatitis. These nuclei are all fine. What we do see, however, you can see the hepatic plates are all broken up, and what you're looking at here is called, or referred to as, individualization of the hepatocytes. Well, I keep going through my tissues and I look at the kidneys and I'm like, wow, there is massive renal tubular necrosis here, and it appears to be quite acute. There's no inflammatory response, and there's sparing of the glomeruli. Those two histologic features suggest another disease to me that wasn't even on the list. And because of that, I go ahead and do a silver stain, and lo and behold, all of a sudden we see the silver positive spirochetes, and we were in fact dealing with a fulminant acute infection of Leptospirosis. Now, I think many of us are used to seeing these beautiful pictures in books of these helical spiral organisms. In reality, when you're dealing with a lot of necrosis and tissues, don't expect them to look as lovely as they do in your textbooks. As veterinarians, I think we are most familiar with the abortion storms associated with leptospirosis, venereal transplacental spread, and I get a little complacent and seem to forget almost about the fact that there can be a direct contact kind of infection. We know that the organisms, preferentially after 4 to 7 days of leptospiremia, will localize in the liver and the kidneys and the gravid uterus. And as I said, I think we are more accustomed to seeing the chronic presentation of this disease with the severe lymphoplasmacytic interstitial nephritis and tubulointerstitial nephritis and the classic pictures. And we're less accustomed to seeing the gross lesions that we saw in the zoo animal. Okay, so we're looking at this in our red panda, and with a massive hemorrhage, and the question you have to ask yourself is, why are we seeing this? I mean, after all, how often when you're working on a dog these days do we see this kind of presentation of leptospirosis? I mean, wouldn't this animal have been vaccinated against lepto? Well, the problem is, as we discussed, we may not be able to use all those vaccines, and the problem is leptospiral vaccine, the bacterin, is part of the mixed vaccine that we use in dogs, which unfortunately induces canine distemper in lesser pandas, so it cannot be used. So no, this animal was not protected. But there's another very important thing to remember. Even if we had vaccinated this animal, even if we'd been able to use the commercial vaccine, in fact, the commercial product only covers the most common serovars of leptospirosis, such as leptocanicola or pomona or interrogans and icterohemorrhagica. And in fact, we were not dealing with one of the routine infections. we were dealing with a Leptospirosis autumnalis infection, and this isolate is most commonly associated with rodents. And the problem is, in a zoo setting, it's a large urban park, many of these asymptomatic hosts are found in large numbers on zoo grounds. This is going to be a problem because the Central Park Zoo is in the middle of Central Park in New York City. And no matter how stringent we might be within the zoo grounds for our rodent control, we also have to deal with the fact that they're going to be coming right in from the other parts of the park. And this is the kind of situation where, as a pathologist, you may have to make some recommendations about how they create their exhibits and really do everything we can to prevent this disease from being introduced. The other thing we are now routinely vaccinating with the leptobacterin for all animals that are at risk. And one more thing that I would mention, this animal was negative on serology initially, not because it couldn't mount an immune response. Even its cage mate that went on to survive 10 days later also was negative on routine leptoserology because they only test for the 5 most common serovars. So as if you're working on the zoo cases, you have to call up your diagnostic lab and say, no, I need the entire panel covering all 17 serovars, and go ahead and do your fluorescent antibody. So don't take a lot of the your ancillary lab tests that you may take at face value with domestic animals. You have to be a little more questioning when you're dealing with the zoo species. All right, now that you try and deal with the answers there, but you're still not done. You haven't completed your job because as a zoo pathologist, again, you would want to warn the zoo curators and keeper staff of the zoonotic hazard. In fact, the person who had been taking care of this animal was pregnant, and we were able to tell her that she needed to discuss the situation with her physician. Okay, leptospirosis is not the only bacterial disease that is introduced by rodents. There's another very serious one that has been a problem for our carnivores and our hoofstock and our carnivores. And this is Salmonellosis, which again can present in both acute and chronic forms. You can have the septicemia, or as we see in this giraffe, hemorrhagic enterocolitis, or you can end up with these chronic infections as we did in this sambar deer. Either way, this disease is very difficult to treat in a zoo setting. Imagine, if you will, the cost of treating an infection of Salmonella in an elephant. On a milligram per kilogram dosage basis, you would easily break the back of any zoo budget within a month. No matter what, the real tragedy is every time we lose one of these animals to an otherwise preventable disease. And we really need to sometimes do a little bit of work here. If you're working on a zoo case, and you may have to do some diplomatic work and convince the curators or the administrative staff that sometimes the only way to prevent these diseases is to spend a little money. And when we had these salmonella outbreaks, I in fact had to spend a whole summer harvesting ligated intestinal tracts from all the mice that we were catching in our traps. All of these were sent to Cornell for salmonella typing, and by the end of the summer we were able to demonstrate that the salmonella isolate that had killed the giraffe was that found of the mice in that building, and a very different kind of salmonella had killed our mouse deer, and it was rather a compelling argument for the need for the zoo to spend money on rodent-proof food storage lockers. Let's prevent them from getting access to our hay or our feed. And when this was done, it greatly decreased the incidence of the rodent-borne salmonella problems in our hoofstock. The problem continued, though, in our carnivores. And why would that have been? Well, I mean, were the snow leopards running through the exhibit catching mice? No. Are they eating hay? No. Well, again, you have to stop and think about the management of these animals. Snow leopards are eating meat, and at the time the practice was one of feeding them raw chicken, which unfortunately in New York State is known to have a very high incidence of salmonella contamination. So you may need to recommend some dietary changes when you make these diagnoses in zoo animals. Well, let us briefly take another look at a rodent-borne disease, which is unusual in that it had nothing to do with contamination of hay or food or something like that, but exposure to the animals themselves. Lymphocytic choriomeningitis is an arenavirus, and Several years ago, we did not know that this was the cause of callitrichid hepatitis, which is, it was given that name because we did not know what the etiology of it was. It did go on to cause fatal outbreaks of hepatitis in marmosets and tamarins in several zoos. All of these animals are critically endangered. This is a beautiful golden lion tamarin due to a severe loss of habitat. And when they had these outbreaks, these animals had hepatomegaly, serous cavity effusions, serosal hemorrhages, and jaundice, and succumbed with a multifocal necrotizing hepatitis with these characteristic acidophilic bodies, similar to those seen in yellow fever in man, these councilman-like bodies or acidophilic bodies. And for many years people thought we might have been dealing with in fact, a yellow fever infection, but we now know, in fact, that this is due to lymphocytic choriomeningitis. And you may ask yourself, well, how is that even, how do they get that? I mean, we tend to think of LCM as being a rather benign infection that we may pick up inadvertently by exposure to hamsters. Well, in fact, in the zoo setting, remember, here we are with our rodents again. Zoos were feeding pinky mice, tiny little mice, to marmosets and tamarins in the wild. These animals had been seen eating small vertebrates, so as part of the behavioral enrichment, this was part of their normal diet. And so in fact, this was essentially an accidental introduction of disease to zoo collections. This feeding practice has been abandoned, and I don't think we've seen an outbreak in a while. Yet again, another rodent-borne disease that can have a devastating impact on some zoos in the United States is Encephalomyerocoditis virus. This is a cardiotropic virus which causes myocardial necrosis with variable mineralization and sometimes a plus or minus mononuclear infiltrate, as seen here. And the animals, when they die, will have obviously foci of myocardial pallor and increased pericardial fluid. This virus has a very broad host range, including not only man, but primates, rodents, birds, and swine. In zoos, the problem has occurred primarily in primates and elephants. And there have been several outbreaks in several zoos. Now, the transmission of EMCV is poorly understood, but we do know that 3 genera of mosquitoes and 2 genera of ticks can serve as vectors, and that rodents are thought to be the primary reservoir, hosts, and disseminators of the virus through contamination of food and water. Now, the majority, Audubon Park Zoo, this is down in Louisiana, makes the point that the majority of outbreaks have occurred in the south, in Louisiana and Florida, and this is a seasonal thing that occurs primarily in the colder months, and they think that it may be because it's at that time that the rodents seek shelter in the zoo buildings. The Audubon Zoo, in their case, the key to eliminating the infection was not only in addition to an intensive rodent trapping campaign, they simply remove the food dishes at night. Something as simple as that. It's not enough to have rodent-proof food storage lockers. If you're going to leave the dish of food out all night where it can then be contaminated by rodents, what's the point? So they took it one step further, and that greatly decreased the incidence of the problem. There was one very bizarre case of EMCV when one of the elephants died. That's a lot of meat. Zoos don't like to see things go to waste, and so the animal was fed out to the carnivore collection in the zoo, and it caused most of their large cats to succumb to the infection. So again, very strange ways to see disease in zoos. All right, one last example of a rodent-borne disease is tularemia. Now, this bacterial disease is caused by Francisella tularensis, which is a gram-negative coccobacillus. Tularemia is transmitted by a variety of blood-sucking arthropods, and it's interesting in that it's one of the few bacteria capable of reproducing and adapting to the internal environment of arthropods, and can serve as a true biological, not just a mechanical transmitter. The disease is transmitted when an animal comes into either direct contact or ingests contaminated water, and it can also occur through aerosolization of dust contaminated with infected fecal material, ingestion of the carcasses, and ingestion of ectoparasites during grooming. The disease is found throughout the United States, although we suspect most people associate it with hunters skinning out rabbits, and they become infected when they're not wearing gloves. And it's true that the majority of human cases are what we refer to as the type A tularemia, which involves the rabbit-tick cycle. However, that type B tularemia, which occurred, is the one that was responsible for an outbreak at this zoo. And in this form, it involves rodents and contaminated water. And the disease causes a severe and fatal septicemia with necrosis in the spleen and the liver and the lung and the bone marrow and lymph nodes. And in all those primates, they grew a pure culture of Francisella tularensis type B. In an attempt to identify the source of infection, they trapped mice in the building and again isolated a pure culture of Francisella tularensis type B. And it was assumed that the primates in that zoo had fallen victim to a local epizootic of murine tularemia. So in addition to mounting a rigorous rodent control campaign, they took another step. They removed the hay substrate. You know, animals are kept in cages or enclosures. They're usually bedded down with straw, and that in itself is a terrific environment for both mice and cockroaches. So again, a very simple management recommendation that can help you stop a disease in its tracks. Okay, so we've talked about disease being spread in a variety of routes. Virus spread through water, duck violenteritis and leptospirosis, viral and bacterial infections through contamination of food and water, EMCV, salmonella, tularemia, but we haven't yet discussed the hematogenous route. All right, so say you get some cases from your local aquarium. You're looking at these penguin liver and you see, oh, you see something there, you see something there, and you go, well, what is that? Gee, looks protozoal. I don't see any necrosis associated with this organism. You take another look at it and you go, well, gee, you know, it doesn't have a thick capsule. It doesn't look like Neospora caninum. I'm still not quite sure where we are here. So what are you going to do? Do you just wimp out and sign this out as, you know, protozoal hepatitis, multifocal, chronic, lymphoplasmacytic, whatever? No, you're going to stop and you're going to go to those literature databases we talked about earlier. You're going to type in black-footed penguin, and lo and behold, you're going to pull up 20 references on this disease problem. You look at your list of articles and what causes mortality in penguins, and there on the bottom, avian malaria. And in fact, that is what you're dealing with. And when you read the articles, you're then going to know that what we're looking at is something that can cause a major problem in many different species of penguins. And the organisms you are looking at are the tissue phase or the non-erythrocytic, the exoerythrocytic schizonts of avian Plasmodium infections. This is just like human malaria, except different in several ways, and we'll discuss. And Plasmodium relictum, Plasmodium elongatum are the two most common things that we see. Again, as in man, this is a seasonal disease due to the fact that it's transmitted by mosquitoes. And you're going to know from your reading that there are 3 species of mosquitoes found on the East Coast. And the other major problem is the fact that there is a very large reservoir population of infected but asymptomatic birds out there. And so the mosquito bites the sparrow and then bites the penguin, and then we get a severe infection. The clinical signs of this disease are quite variable, and there's often no antemortem blood work. Even if there were, this is not an easy infection to pick up on blood smears, and so it's pretty easy to miss. Gross lesions, we often have sudden death with an enlarged liver and spleen, and a lot of edema. Now, ideally, if we now know the vector, ideally you would want to prevent exposure, but that may or may not be practical in an outdoor aquarium situation. However, this disease can be prevented through the use of antimalarial drugs and a combination therapy of chloroquine and primaquine, and that is used by some institutions. As I said, it may not be easy to pick up clinically on circulating on your blood smears, looking for circulating forms, so it's imperative this disease not be missed on your review. Okay, mosquitoes are also involved in the spread of another disease, avian pox. And We know that mosquitoes can transmit this infection through cutaneous inoculation. The birds develop primary or secondary viremia. We get these classic histo lesions involving usually the non-feathered skin. And with these large eosinophilic cytoplasmic inclusion bodies known as Bollinger bodies, you get epidermal hypertrophy, epidermal hyperplasia. And depending on the species of bird, the age and its resistance and the strain of the virus, we can see the several different forms. The cutaneous form, the diphtheritic or the wet form, the septicemic, and even in some species, as in canaries, we can see tumors or quote-unquote tumors. You get these pulmonary adenomas that develop in the lung, and if you look carefully though, you'll see these intracytoplasmic inclusions in the so-called neoplastic cells. So this can be a devastating disease for zoo birds. And as in any pox infection, when one of these pox fall off and end up in the soil, these particles remain infectious for a very long period of time. So if you're ever dealing with a pox infection in any zoo animal, not only do you have to tell the people that this virus is hardy, very resistant to disinfectants, you may have to give them some advice on to how to disinfect that exhibit. And you're going to also have to tell them or suggest that they might want to burn the bedding to get rid of the virus. Another way, another hematogenous non-arthropod-borne method of viral entry is through bite wounds. Rabies, we had the first case of rabies in New York State, in New York City for 50 years, and the only reason we were able to pick this up is because we had been running a surveillance program for 8 years. So we found the first skunk, and I'm glad we were able to find this because we now vaccinate all our at-risk animals, and I'm much happier we identified it in a skunk versus an elephant. And it underlines the need for vigilance when you're working in a zoo setting. All right, let's just take a quick look at substrate-related problems. Don't forget, some of those beautiful exhibits I showed you, the floor of those exhibits is going to be soil. And say you have this beautiful bird of paradise with a miliary hepatitis. And what we're looking at is avian tuberculosis. And let's see, 1, 2, 3. In another 3 slides, we'll be changing carousels. But right now, let's just take a look at the intestinal form of avian TB. It almost looks like Johne's disease, very thickened. When you look at the lamina propria, you'll see that it is filled with foamy macrophages. And if you were to put an acid-fast stain on that, the field would light up with acid-fast bacilli. Okay, well the problem is when we have those ulcerative intestinal lesions, all of those acid-fast bacilli are going to go into the exhibit where that bird is kept in the soil, and then it will then be picked up by other birds that are pecking around in that exhibit. Our greatest problem and challenge as pathologists today and facing the zoo community really is the current lack of accurate and reliable sensitive antemortem method of diagnosing this disease. Because even if you were to recommend to a zoo that they depopulate that exhibit, there's no guarantee whatsoever that they won't introduce this infection the next time they bring a bird in from another collection. So what you can do though, as a pathologist, at that necropsy, if you saw that liver, you do an impression smear, you do an acid fast on your cytology, and with 1 hour, you can tell them that they have an infectious disease problem, and perhaps they don't want to move its cage mate, maybe they don't want to send that bird to another zoo, and at least we can further prevent the spread of that disease. If you don't have time to do an acid fast, you can do a really quick diff quick. Mycobacteria have a very thick capsule, and you can see all these little ghosts, these little white outlines, because they fail to pick up the stain. Okay, let's look at one quick last example of diseases which threaten zoo animals. You see these lovely baby gorillas with little vesicles on their face and on their feet. You get an intact vesicle on your histo or on your biopsy specimen. And as you're scanning around there, we see both intranuclear inclusions and syncytial cells, which is a real concern. You better be concerned about it. This is a primate. You worry about herpes infections. And, but in fact, this was not the herpes you're thinking of. This turned out to be chicken pox. This is a human infection. It's usually highly host specific, but in this case, it will be transmitted to other primates. There's been outbreaks occurred at the San Diego Zoo, at the Moscow Zoo, at the Henry Dorley Zoo, and most recently we had these cases at the Bronx Zoo. In all instances, these outbreaks have been associated with exposure to humans. And, you know, it's a problem because it is a highly infectious disease with airborne transmission. And that's why it's very important to wear masks whenever you're working with primates, and unfortunately they only work if they're on your face. So it may fall upon you as a local pathologist working with a zoo collection to warn the curators about the need to develop primate protocols, help them create protocols that can be adhered to on a day-to-day basis, and then we can avoid some of the potential complications you might see, such as pneumonitis or encephalitis. And we were lucky that we were dealing with baby gorillas, because apparently it seems to have a course similar to that in children. If we'd had an adult outbreak, it might not have gone as easily. So help these zoos create the kind of disease control programs that they need. We are the disease experts and they need our advice. All right, so overall, we've looked at you know, a number of different ways that disease can be introduced to zoo collections. As you can see, it's not as straightforward as it might be in domestic animal pathology. We've discussed some simple and practical measures to prevent introduction of disease. And I think the zoo pathologist, however, must always be standing guard. We're the first alert. We're the ones who send off the first alarm of a disease problem. It may not be easy, and remember, we're not dealing with university or even with veterinary staff in all cases, and you'll find yourself doing a balancing act. And since we don't have necessarily straightforward answers to some of the questions and these issues that are raised with these disease problems, some people would prefer to bury their heads in the sand, and because they don't want to deal with them. But I think you have to just deal with the issue head on. You may lock horns over some of these issues, but I recommend you hold fast. Ultimately, everyone wants to do what's best for the animals, and they'll be best served by addressing these issues. I hope you've all enjoyed this peek into the field of zoo pathology, and that you'll all be ready to dive in, because zoos certainly need the best we have to offer. Okay, well, now we're going to get into the highly specialized area of reptile and amphibian pathology. And when you do so, I think you have to be prepared for a few surprises. To help you deal with them, in your handout, as I said, which is on the homepage of the C.L. Davis Foundation on the web, I've provided you with an outline of major disease problems of frogs, snakes, and turtles. Where possible, I gave you the Wednesday conference slide and the video disc numbers that accompany those diseases. Page 27, you have a listing of general references, and pages 28 through 38 are recent references on herpetology. In addition, there's another source of information, the Herpetologic Index, which is a very inexpensive and a great resource of information. This thing has thousands of citations on amphibians and reptiles. I'd also recommend you might want to consider, if you're going to be doing any amount of reptile and amphibian diagnostic path, becoming a member of the Association of Reptile and Amphibian Veterinarians. They often have excellent review articles in this bulletin, and it's also a nice way to promote growth of this field. Remember, also, in terms of available histology, you can get normal glass slide histology sets on the alligator, the rattlesnake, the red-eared slider, and the southern clawed frog from the Registry of Comparative Path at no cost through interlibrary loan. At the very end of your handout, other AFIP information, you have a listing of the available reptile and amphibian glass slides from the Wednesday conference seminar series. You have the dates, so if you're at a university, go to your file and pull out those slides and review them after you've looked at this videotape. On page 41 through 52, you have a list of reptile and amphibian accessions in the University of Georgia Noah's Archive video disc. Some of my seminar slides are on the disc, and you'll note in the handout that if they have an asterisk, that means you'll be able to look at them again on the video disc. All right, well, we have a lot of material to cover. As you see, when you go through the handout, I've approached this as if you were doing a necropsy. We're going to start with external examinations, and we're going to move through each organ system. And as we do so, and as I emphasized earlier in the first lecture, we need to go through all the potential categories of disease, viral, bacterial, fungal, parasitic, toxic, nutritional, etc., and generate differentials for each one of those disease categories. Before we do that, let's first take a quick look at some normal anatomic and histologic features, some of which have a bearing on the kinds of disease problems we see. There are more than 3,400 species of frogs and toads. Many of them can be as tiny as this little rain frog from Brazil, weighing less than a gram. Some of them can weigh up to 4.5 pounds, such as this Goliath frog. They do have some external characteristics that are interesting. If you pick up your frog and you'll notice it feels kind of squishy. Well, that's because frogs really have no ribs. They have a very simple musculoskeletal structure. They have a head and a trunk. They have an atlas, and then they have vertebrae 2 through 8, which have short transverse processes. And then they have a blade-like piece of bone, which is a fusion of the caudal vertebra. That's known as a urostyle. If you look at the forelegs of a male frog, you'll see 4 toes, and you may see quite prominent thumbs. And it's possible that the tissue covering that may be very thickened and roughened and heavily keratinized. Do not make the mistake of assuming this is pathogenic. This is a seasonal occurrence. It's under the influence of testosterone. When their thumbs become roughened, they're called nuptial pads, and the male frogs will use them to help them clasp the female during amplexus, wherein the female releases the egg mass, and then the male fertilizes them externally. This is perfectly normal. Another thing you want to look at is the tympanum in some species of frogs. You can use this to help you identify the sex. In the Rana species, the male's tympanum is twice the size of the eye, whereas in the female it's the same size. You want to look at your eye. You'll notice in frogs they have a very well developed eyelids, and the lower lid sweeps up across the eye to sweep it free of debris. They have a transparent third eyelid which protects the eye when the frog is submerged and prevents drying of the cornea when they're on land. And as in all species, the cornea should normally be clear, moist, and free of opacities. We need to spend a little bit of time on the skin because it's actually one of the most important organs in amphibians. Like snakes and other animals, the frogs and salamanders will shed the outer layer of their epidermis, and this can be important in the completion of certain parasitic life cycles, as you'll see later in the seminar. But as you'll notice when you look at the skin, we have a really complex vascular network and abundant mucus glands. The mucus glands are what provide the amphibian with a slime coat it protects the animal and keeps it moist, and it also decreases friction when swimming. Frogs need that vascular capillary network there to help them with their cutaneous respiration. This is what makes it possible for frogs to bury themselves in the mud when they're either under hibernation or estivation, and it allows them to survive. The other thing you want to notice is the pigment cells. Don't assume that those are all melanophores. In addition, they have a series of normal pigment cells called chromatophores. And in certain species, I think we're all aware of the toxins that we can find, the toxic alkaloids in the parotid glands of certain toads, these localized toxin production. But in some species, it's more diffuse, as in this poison arrow frog from South America, and it has its name for a very good reason. This is one of those frogs used by indigenous people to, they'll dip their arrows in the toxin produced by the skin of these frogs and use it to hunt their prey. The interesting thing about these guys is we now know the Botanical Gardens did a study in South America with NIH. Apparently these frogs will lose a lot of their toxicity in captivity. That is due to the fact that many of the toxins are related to their diet of the insects found normally on the jungle floor. If you bring them back to New York and feed them fruit flies, they become non-toxic. Still, you never quite know what you're dealing with, so I would recommend if you're working with these things, you always are double gloved. All right, so overall, the skin of amphibians plays a critical role in both the respiratory and osmoregulatory function, and because of it, it makes them very sensitive to any management problems. They're sensitive to dehydration. Something as simple as putting a heat lamp too close to an amphibian can cause fatality. Since their skin is a freely permeable barrier, membrane, freely permeable to water, you can run into problems if their containers, the fish tank or the barrel where they're being kept, has not been properly rinsed following disinfection, as was the case with these animals. Most of all, the quality of the water in which they're kept is critical, and poor water quality results in most of the problems we see as pathologists. All right, so let's take a quick look at some of the problems in these systems, the eye, the musculoskeletal, and the skin. Xanthomatous Keratitis was first described in Cuban tree frogs, and at one point people believed it might have had a genetic origin, but we now know that this affects a large number of different species of high-lid tree frogs. These animals will develop a lipid keratopathy with cholesterol deposition in the cornea and often the viscera, and the animals die not only because of starvation, because they can't see their prey, but due to disseminated xanthomatosis. We now know that this disease is directly related to management, and it was due to the feeding practice of giving these frogs pinky mice, which happen to be very high in cholesterol. In the wild, these animals would normally be eating insects. That management style has been abandoned, and I think the incidence has greatly decreased. I don't have any pictures of the musculoskeletal problems you might see as a pathologist, because we have a full-time nutrition department and an excellent nutritionist on staff, so we don't see the calcium phosphorus imbalance problems which can be a very big problem in tadpoles, because they do have a very high requirement for that. If it is a problem, you may see scoliosis or folding fractures and paralysis. The flip side of that is sometimes animals are over-supplemented with vitamins, and you can end up with spindly leg syndrome in dendrobated frogs, and they believe that may be associated with excessive supplementation. By far, though, the most common thing we're going to see as pathologists in amphibians are gram-negative septicemias. This is the most common cause of morbidity and mortality. And this is what will cause this lesion, what classically is referred to as red leg, with good cause, because we can see the severe petechiation and the hemorrhage in the skin of this bullfrog. The bacteria most commonly associated with this is Aeromonas Hydrophila, which is a gram-negative non-sporulating motile rod. This bacteria emerges as a pathogen in cold-blooded animals because it grows best at a temperature of 37 degrees centigrade. In acute cases, you may not see that hyperemia, or in the case of a highly pigmented animal, it'd be a little hard to pick it up, really. But often we will see simply ascites and sudden death. Aeromonas can also cause a panophthalmitis, as it did in these fire-bellied toads, and an otitis interna, so you'd want to consider that as a differential. And while Aeromonas has been experimentally proven to cause this disease, it has also been associated with other gram-negative bacteria such as Pseudomonas or Proteus. A technique I would mention is if you're dealing with a moribund amphibian, or you're giving information to clinicians, because of the fact that these animals have abundant lymph channels underneath their skin, you can milk the lymph down into the dorsal lymph sac of the leg, and with a tuberculin syringe aspirate some of that lymph and submit it for culture, and chances are you get a pure culture of Aeromonas. Okay, another bacterial skin infection you would need to consider, and one that might not necessarily pop into your head if you're accustomed to working with dogs and cats, is that of cutaneous tuberculosis in amphibians. This ulcerated lesion you're seeing here is due to one of those atypical mycobacteria. These were first described back in the 1800s, and in fact this is the oldest known disease of reptiles. But even though we've known about it for more than 100 years, there's still a lot we need to learn, because the veterinary community by and large has paid very little attention to this. Although this can be a zoonotic hazard, it will cause fish tank granuloma, where it causes a local skin lesion in man, because these bacteria, just like with Aeromonas, require or do best at lower body temperatures. They really don't present a very serious problem for higher warm-blooded mammals. You would need to do isolation. You could be dealing with any one of these species of mycobacteria. These are all found or in the soil and the water, and even though in some of the literature it may say that the incidence of the disease is low, but in fact I think it may be due to underreporting. We certainly see quite a bit of it with the amphibians we see. In all cases, these mycobacteria require some kind of breach in an epithelium to allow acid-fast bacillary access. The epithelial damage can be any number of routes. If you have some kind of skin abrasion, you can end up with a cutaneous form of TB. If you had a viral or parasitic pneumonia which damaged the lung tissue, you can end up with a respiratory form. Or if you had a parasitic or viral enteritis, you can end up with enteric damage, and that can be a nice entry route. The source of infection is usually contaminated water. However, in the case of frogs, insects have also been incriminated as a potential source of infection. the primary lesions that we see reflect the route of entry. Now, the most common form in both snakes and amphibians is what we call the hepatosplenic form, but I would remind you that there is a primary cutaneous form in amphibians, and that you need to bear it in mind when you see that kind of lesion. So if you did see something like that, you would want to, if you had a biopsy, you'd want to remember to put an acid-fast stain on that, or maybe you do an impression smear. And also, if you see something like that, you're going to want to freeze that tissue for future mycobacterial isolation. And I would caution you that unlike the avian mycobacteria, where you classically see myriads of organisms, it may be much more difficult to pick up the atypical mycobacteria, and the number of bacilli can be quite sparse. Another infection caused by bacteria in the skin of amphibians is that caused by Chlamydia psittaci. This has been associated with very high morbidity and mortality in African clawed frogs and several other frog species. It results in cutaneous hemorrhage and hepatomegaly and splenomegaly and multifocal necrosis of the liver, spleen, kidney, and heart. And this you would be able to diagnose through your routine chlamydial stains. You put a PVK stain on your tissues or on your impression smears. You'll find those intracytoplasmic basophilic inclusions. Okay, continuing on in skin. Another category disease that can be a problem are fungal infections, and this is in fact a very important one in amphibians, called chromomycosis, sometimes called chromoblastomycosis, although the organism itself is not really a blastomycete. This infection causes a severe granulomatous dermatitis, and you can see mass lesions like this, or like this. And on histology, what you will see are these characteristic pigmented fungal elements. These are naturally brown colored, and that's why these are called dematiaceous fungi. And these funny little things that almost look like coffee beans, these are called the muriform or the sclerotic bodies. And you can see they're engulfed in a giant cell. And this infection is actually caused by a number of different fungal species, Phealophora or Cladosporium. You would actually need to do fungal cultures if you want to know specifically which one it is. They're all found worldwide, especially in the soil of tropical areas. This is an infection that's described in people in South America. However, the bottom line is, unfortunately for the amphibians we really have no effective treatment for this. We often don't go to the trouble of trying to do cultures because it really is a moot point. However, we do know that the infections are acquired via abrasions, and also possibly, as we said, the enteric form. You'll see later that frogs have a very fleshy tongue. They're rather non-selective feeders, so when they zap that tongue out to get hold of some kind of insect, they may pick up a wood chip that's contaminated with mycobacteria. Maybe the wood chip penetrates the stomach and causes a little splinter or something like that, and that can also be a route of introducing mycobacteria systemically. Okay, another important skin lesion to consider is that of saprolegnia. This is an aquatic mold that grows on wounds and ulcers, primarily in salamanders, mud puppies, axolotls, and produce those nice cottony growths that they talk about. And histologically, you're going to see large mats of these mold, and clinically, they often remove these and treat these animals topically. But the big thing to remember is if you make this diagnosis, don't just sign it out as a morphologic diagnosis. The next step is you have to discuss with the curators the fact that this is associated with low environmental temperatures and that perhaps we need some kind of management change to prevent further infections. Another interesting fungal infection in frogs is that of Basidiobulus. This has been a serious pathogen in the Wyoming toad. And you can see these very unusual fungal organisms in the skin. This is a zygomycete, an entomorthomycotic organism, and it is associated with high fatality. Okay, moving on. We talked about bacterial and fungal. Let's look at some parasitic infections in the skin of amphibians. Capillaria xenopodes is a nematode which tunnels its way through the epidermis. And as you can see on this slide, and you will see cross sections of gravid adult nematodes with larvated capillarid eggs. And The nematodes themselves cause some epidermal desquamation and darkening and roughening of the skin. Frogs may harbor this infection for months, but it can cause eventual death. Continuing on into parasitic, don't forget your protozoa. You don't have to worry about these only in fish. You may have to worry about these in amphibians as well. This is an example of Trichodyna, but we could also be seeing Oodinium, which is a flagellated protozoan found on the skin and gills of tadpoles, axolotls, and newts. Might have been Dermocystidium rani, which causes disfiguring cysts in frogs, or Dermospiridium granulosum. All of those would need to be considered. Remember, you might want to do a wet mount at the time of the necropsy. If you throw these things into formalin, a lot of the external protozoa simply float away and end up in the sediment of your formalin on the bottom of the jar. So if you're working with amphibians and you see a lesion, consider doing a wet prep and evaluating it at the time of the necropsy. There aren't many examples of cutaneous viral infections of amphibians, but one of them that has been reported is tadpole edema virus. This has been reported in the American bullfrog tadpoles up to 2 months of age, can cause severe subcu edema, petechiation, and multifocal necrosis, and it's one which you would need to consider. All right, we're finishing up with one last slide, and then we're going to be changing carousels. There is another unusual disease problem seen in amphibians, and this is a direct management-related problem, and that's known as gas bubble disease. And remember, these amphibians are kept in an aquatic environment, and sometimes something goes wrong with a pressurized filtration system, and it results in the water being supersaturated with air. These animals will end up with hyperemia and hemorrhage of the skin, and the thing to look for are these little sub-Q bubbles, especially between the interdigital webs. On biopsy, you'll just see big air bubbles on your slides. If they survive, these animals unfortunately may go on to develop a secondary bacteremia. Okay, so let's just summarize what we just saw in those skin lesions. We talked about a variety of pathogens, but as you see, many of them can present with rather similar gross presentation. So we're going to consider doing our impression smears. Remember that cutaneous TB, you're going to do an acid fast. Possible chlamydia, you're going to do your Giemsa or your PVK stains. You're obviously always going to be doing a gram stain to look for those gram-negative organisms. For those cutaneous protozoal infections and fungal infections, maybe you want to do skin scrapings, bacterial and fungal cultures. Remember to freeze tissues. You might need that to do mycobacterial isolation down the road. And you may want to aspirate for bacterial culture. All right, well, let's move on now. You've completed your external examination, and you're about to go on and do your actual dissection. If you open the mouth of a frog, you'll see that very pink fleshy tongue I was talking about. That's the one that they'll zap out when they're trying to get the insects. If it's a male, you'll also see these paired vocal openings which go into the vocal sacs, and that's how frogs croak. Helps them resonate and increase the volume of their calls. All right, you're going to make your ventral incisions, and you're going to reflect the skin laterally. As you do that, be sure to evaluate the lymph sacs over the back and legs. As I said, these are they have a large volume of lymph that flows underneath their skin there. That's what's easy to aspirate, and it's an interesting feature. Be sure to evaluate it. Take a look at their sternum as you're reflecting things. The amphibians were some of the first animals really to develop a sternum. All right, once we have them open, we want to evaluate the musculature. There are certain parasites we need to consider. One of them is Pleistophoria. This is a microsporidian parasite, which causes chronic illness and wasting in the bufo and high mortality, and you can see these lesions on histology. Another parasitic infection of muscle we need to consider, now this is a trematode, is that of Alaria. This flu can be normally found, or not normally, but it can be found in large numbers in frogs and tadpoles because they do serve as the intermediate secondary host. It can be a problem for the frogs if they're present in large numbers. This can also be a problem for man. There's a case of a human fatality where some poor guy ate undercooked frog legs, and each leg had more than 3,000 mesosacharia. So it makes you think twice about eating frog legs, huh? I don't eat too much sushi either, I'll tell you that. So if you don't see anything like that, you continue on, you open up your frog. Basically what you're going to see is the liver, the heart, the very simple GI tract. try and find the spleen immediately. Of all the organs that are missed on exotic animal necropsies, it invariably turns out to be the spleen. It's usually small. It's easy to miss once you've stripped stuff out. So I always recommend to people, if the moment you identify it, remove it, put it in a cassette, and make sure it won't get rinsed away when you're draining your tissues for trimming in. If it's a female, you may not see an awful lot because well, here we have our nice heart, and we have the liver, and we can see some simple intestinal tracts. If it's a female frog, when you open it up, you may not see much other than a large ovarian follicular mass. You're going to have to remove that before you can see anything at all. Okay, let's move on to the heart. Frogs typically have a very primitive reptilian heart, which consists of a single ventricle and two very well-developed atria. The IV septum is incomplete. However, the mixing of oxygenated and deoxygenated blood is largely avoided due to the presence of thick muscular ridges and current flows within the ventricle. These reptilian hearts are what we refer to as trabecular or sinusoidal hearts. You can see all those muscular ridges. Remember, during hibernation or low environmental temperatures, or during periods of estivation when environmental temperatures are very high, the heartbeat of an amphibian may be barely perceptible. Okay. Here's a heart with some granulomas. I'm not going to get into any really specific cardiac pathology today. Just be aware that you can see granulomas in the heart from gram-negative infections or mycobacteria, fungal, parasitic. Visceral gout is an important one, pericardial gout, but you'll see a very nice example of that later in the seminar in a snake, so we're not going to get into that now. Before we leave the cardiovascular system, I would mention just one technique that you might want to consider, and it's that of aspirating cardiac blood at the time of necropsy and making a smear. It's very common to find blood-borne Spirozome Parasites in amphibians. Trypanosoma inopinatum is fatal to Old World anurans. Trypanosoma demictali is fatal to American newts, and Trypanosoma pipientis can cause splenomegaly in leopard frogs. And there's a very long list of blood-borne sporozoa in amphibians in your reference section. It's an interesting thing to consider. Okay, let's move on to amphibian lungs. And this is just a nice little granuloma in the heart, and that was chromomycosis. Amphibian lungs are, again, quite primitive and essentially like a balloon with a prominent reticular pattern. On this slide, this animal has a severe pneumonia, but what I was trying to illustrate were the large bundles of smooth muscle within the lung to help them forcefully expel air. And now remember, the reason they can get away with very primitive lungs, don't forget they have that capacity for cutaneous respiration, so they're a little less dependent on pulmonary exchange. And so let's see, here we have a very interesting presentation of a bacterial disease in an amphibian lung, which would be relatively easy to miss as a pathologist. Say you see a set of lungs like this, and you cut them in, and histologically what you see, there are some macrophages, but it's a predominantly heterophilic infiltrate. And so you look at this and you go, well, that's probably a gram-negative septicemia, and that you sign it out as such. In fact, you may see some gram-negative bacteria there. But if you scan around, or if you take the time to cut in some additional sections, unfortunately, there's a giant cell there. And what we're looking at, if you put an acid-fast stain on this, you'll see these little filamentous acid-fast bacilli. And in fact, we're looking at the respiratory form of amphibian tuberculosis. This is called the nasopharyngeal form. It's predominantly heterophilic, and you do need to have an index of suspicion to put an acid-fast stain on this to pick this up. However, you will, in addition to the so-called acute form, you can also see the chronic form of mycobacteriosis. And either way, you do need to have that very high on your list of differentials when you're dealing with amphibians. Let's look at some parasitic infections of the lung. An interesting one is called Rabies. This is a nematode, a strongylid nematode, which in low numbers is not very pathogenic to the frog. However, in high numbers it can cause pneumonia and failure to thrive, especially in your smaller species like your dendrobated frogs. It's also been reported in toads and snakes and chameleons. It has an interesting cycle, and the embryonated eggs, as you can see down here in these lungs, are coughed up, swallowed, shed in the feces. Larvae then mature in the soil where they become infective. They spread to a new host either through ingestion or through percutaneous transmission. Now, an interesting way, how are you going to diagnose this pulmonary infection in an amphibian? You're going to do a fecal exam. Then you're going to identify the embryonated eggs. So again, an unusual, a different little twist on something in terms of diagnosing disease in a zoo animal. And again, before you're done, not only will you recommend that they do fecals, but you're going to have to inform the person who submitted the material that they will need to decontaminate their environment if they wish to prevent further infections. All right, fungal infections. We already went through chromomycosis in the skin, but again, it can occur anywhere, and here we have all those nice pigmented fungal elements in the lung tissue. So, wrapping up with lungs, the procedures we need to consider with amphibians is we're going to do acid fasts and gram stains, we're going to do bacterial and fungal cultures, we're going to freeze for mycobacterial ID, and we're going to do fecal exams to rule out that pulmonary nematode Rabies by identifying the embryonated eggs on fecal. Okay, let's move on to the urogenital system. Frogs have an interesting thing. These things are called fat bodies. You see these fronds of elongate finger-like projections of adipose tissue. They don't have any sub-Q fat stores, and although, you know, and some of we're only talking about amphibians. Certain reptiles will store a lot of fat in their tail, or in, but we'll get into those later. The kidneys are reddish brown and elongate, rather simple. The adrenals are slender and found on the ventromedial surface in the interrenal tissue there, really. And you can see the testes there. Here's some adrenal tissue, and these are some kidneys. Here are some fat bodies. They just happen to have some serosal nematodes or parasite cysts on the surface. That's very common. When a female amphibian is about to lay her eggs, the egg mass will travel down the oviduct, and it acquires a gelatinous covering. The female, when conditions externally are just right, often we don't really know what those conditions need to be, will release the egg mass, and then they will be externally fertilized by the male. There are two very unusual exceptions to this. The Suriname Toad female carries eggs which develop into tadpoles in the skin of her back. And then salamanders, which have internal fertilization and have been known to store spermatophores for years down by their cloaca, can give birth without any recent history of mating. Interesting. Continuing on with the urogenital, something most pathologists are aware of is a viral infection which causes Leucase renal adenocarcinoma. This is caused indeed by a herpes virus, and the virus itself is very interesting in that not only because it causes a tumor and causes this adenocarcinoma, but because it has two distinct temperature phases. In the winter phase at 4 to 9 degrees centigrade, the virus can replicate in the renal epithelial cells and will cause cell lysis and shutting of the virus. And at that time, you will isolate the virus and you will see intranuclear inclusion bodies. At the summer phase at 22 to 25 degrees centigrade, no inclusions will be found. You will be unable to do any isolation. At this time, the virus has been integrated into the renal cell DNA, and it's caused neoplastic transformation, resulting in the adenocarcinoma you're seeing here. Just finishing up with renal and urogenital, there are a few protozoal infections to consider in the kidneys, renal entamoeba and renal coccidiosis. And then there's a very interesting one, microsporidial oophouritis. This is caused by Microsporidium schützii, which infects and causes oocyte hypertrophy, and it's associated with the presence of intraoocytic microsporidian spores. And these enlargement is called a xenoma when the host cell proliferation is induced by an intracytoplasmic parasitic proliferation, and that's been described and associated with a number of microsporidian species. Finishing up with the GI tract, the liver of an amphibian normally will be very dark. It can almost look black. If you're working on a marine toad, when you make your first incision, it'll almost ooze an inky-like substance. This is normal melanin pigment. Amphibians do have gallbladders in most cases, and what we're looking at here, you can see a liver with some of the normal pigment and massive numbers of granulomas. At this point, I would like to refer you to your reference section to the article published by Dr. Montali in the Journal of Comparative Pathology on the inflammation of higher vertebrates. volume 99, 1988. Dr. Montali does an excellent job describing the difference between the normal mammalian immune response and that we're seeing in the ectotherm. Remember, a granuloma is a granuloma in a cold-blooded animal. They have what is called a universal granuloma response. All they want to do is wall things off. Yes, there are heterophilic and histiocytic granulomas, but at the end stage, when they're quite mature, they can look very much the same. So you would need to, and what we do, we just routinely do acid-fast stains on all granulomas just to be sure we don't miss anything, because it's quite possible that's what you might be dealing with. Finishing up with the intestines, the GI tract of amphibians is really quite simple. A large fundic portion of the stomach, short, simple intestines. Frogs can avert their stomach when they want to reject a noxious meal. And something we commonly see, remember we were talking about how they can be intermediate hosts for many parasites. Often we'll see a lot of serosal encysted parasites, which may or may not be causing any problem for the amphibian. However, when you see something like this, where these amphibians, they're actually buried in the mucosa and we see associated inflammation, then we sort of tip over the balance and we know that we're dealing with something that was harmful to the animal. Protozoa can also be a problem. I think we tend to think of amoeba only in snakes. Remember, entamoeba can be a problem also in amphibians. And it can also be a big problem in axolotls. So don't forget to include all of those in your list of differential diagnoses. Another thing to consider, fungal infections. This is a nice mycotic, chromomycotic gastritis in this frog. And finishing up bacteria, let's not forget the good old Salmonella species, which can cause anemia and diarrhea. We know that a lot of reptiles and amphibians can be subclinical carriers, but in many cases we do see it associated with disease, and I would not simply dismiss that. Okay, well, let's move on to snakes. As with the frog, things are not always as they seem. When you look at these first three slides, what you're seeing is some areas of pallor in the musculature. Keep moving. Ooh, I see a lesion there, and gee, bingo, look at that. We have these two nice linear areas of hemorrhage that seem to be evenly spaced, and what we're looking at is an Asiatic Cobra that was envenomated by its cage mate. That's not supposed to happen, but in fact it did, because you know, there are a lot of things we still don't know about these animals. There's apparently a lot of variation in susceptibility to these venoms on a geographic basis, even within the same species. All right, let's take a look at some external species here. External characteristics of these species. Unlike the frog, which had really no ribs, when we're looking at snakes, they've got nothing but ribs. And if you wanted to take the time, you know, they can have up to 160 to 400 vertebrae, and if you're looking at a snake, the number of these vertebrae corresponds roughly to the number of transverse scales on the ventral surface of the snake. They have very complex muscle attachments, which allow them to have the suppleness of movement, and when they do move, those ventral scales are lifted from head to tail successively. The edge gains purchase on the ground, and it pushes them forward in rectilinear movement. Very, very interesting the way they're put together. Something else you might see, I don't have photographs of them, but they're certainly in the textbooks. If you're working on a male python or boa, you may see these little horny spurs on either side of the cloaca, and these are vestigial pelvic girdles, and these little spurs are used to stimulate the female in breeding. Male snakes have paired intromittent organs called hemipenes. They're recessed into diverticula, caudal to the cloaca at the base of the tail. We can sex snakes by inserting a probe excuse me, into the diverticula, and in the case of the male, the diverticular are approximately 7 to 12 subcaudal scales in length, whereas those in the female are usually 3 to 5. Unlike the moist skin of amphibians, the snake skin is adapted to a dehydrating terrestrial existence. It's normally shiny, dry, free of swellings. When you look at a snake scale histologically, you'll see that it's an infolding of epidermis and dermis. The outer layer is keratinized and is periodically shed as a snake grows, and this is normally called ecdysis. Now, unlike amphibians, which have a lot of mucus glands, when you look at the snake skin, as you can see, it's aglandular, with the exception of certain musk or scent glands in the cloacal region, and in crocodilians are found along the inner aspect of the lower jaw. Also in iguanas, you'll find those femoral pores on the legs, and those produce a holocrine secretion. In addition to this, we're going to also see, when we're looking at the skin, those chromatophores that we mentioned in the frogs. Excuse me, I'm sorry, my throat's giving out. Let's take one more look at the melanocytes, though, and in fact we know that certain chameleons and many tree frogs are capable of changing their color. They do that through contraction and expansion of the amoeboid processes of the melanophores when they're stressed, and this response is under neuroendocrine control. Okay, let's take a look at the skin system. A lot of problems are referable to that and that you're going to see as a pathologist. This is an example of an animal that's had difficulty shedding. This is called dysecdysis. And when snakes want to shed their skin, they require a 50 to 60% humidity. They require a pan of water and something rough to rub against to get them started. And so they'll rub their snout against a rock or a branch. Then they literally crawl inside out of their skin, and in doing so turn that shed inside out. At the time of shedding, they will also shed their spectacle. We talked about the eyelids in frogs. Well, snakes do not have eyelids. They have something, it's like a permanent contact lens on their eye, which is a fusion of these embryonic lids. And it's normally shed at the time of, there we go, that's your spectacle there. If it is not shed, if you have a retained spectacle, we can end up with fluid accumulation. As you can see in this case, this can be infected and we can lose the eye. You have to be very careful clinically when you're trying to remove this, because you can do damage, significant damage to the cornea if you try to just simply abruptly remove that retained spectacle, and you have to always soak the snake and get it at the proper environmental temperature and humidity and sort of nurse it along until that can be removed. Let's look another look at the skin. Even though their skin is tough, certainly much more tough than that of an amphibian, snakes are susceptible to external trauma. Some of it can be related to the behavior of the snakes. Indigo snakes have what's called seeking behavior, which means if you cover the top of their fish tank with a screen, they'll often end up with rostral abrasions from rubbing their nose against that in an attempt to get out or seeking prey. Let's not forget the fact that many reptiles are fed live prey, so often we will end up with rodent bites, because the rat gets a few good bites in before he bites the dust. Heating pad burns can be something that you will see, and the problem with that is often they will become secondarily infected. And toxic insults can occur when disinfectants have been used or some kind of toxic bedding, and that was the case with this snake, where microquat was not sufficiently rinsed from the barrel and the snake succumbed within a very short period of time. Continuing on with skin, let's look at parasitic. If you're dealing with snakes that are coming in from the wild, they may arrive with a very heavy tick burden. Amblyoma, ornithodoros, hyaloma ticks have been reported. We know that these will cause focal ulcerations that can cause anemia, and they can serve as vectors for various pathogens. Another parasite associated with the skin is the skin mite, called Ophionosis nutricis. This is associated with excessive crowding in snakes. The mite can cause anemia, but even more importantly, this parasite has been associated with the transmission of Aeromonas Hydrophila, and it may also be associated with the transmission of boa inclusion disease, but don't hold me to that. We used to put little Vapona strips in the cages of snakes to deal with this, but those have since gone off the market, and people have switched to a product which is used to control human head lice. It's called Nix, and it comes in a spray form. And in addition to treating the snakes, the other thing you also want to tell your clients is to be sure to remove the shed skin. You don't want to leave any of those sheds around, because they often have a very heavy mite load. Continuing on with parasitic, You can see a wide variety of encysted parasites in the subcutaneous tissues of snakes. You can see subcutaneous cestodes, such as the pseudophilidian cestode Spirometra. You can see subcutaneous trematodes, such as Alaria, which we already discussed in the frogs. Subcu nematodes, McDonaldius is a serious one. McDonaldius oshii is a filarial nematode that can cause a severe vasculitis and a secondary dermatitis. We also need to consider the dracunculoidea nematodes, which can also cause a pustular dermatitis. Fungal infections can occur in the skin of snakes. However, these are not going to be the ones we routinely see, well, I mean, they may be, but by and large, the trichophyton and the microsporum that we're accustomed to seeing in dogs and cats are not as common in reptiles. In the case of this elephant snake with this multifocal proliferative dermatitis, this was in fact a case of candidiasis. All of these different species of fungi have been reported in snakes. This chuckwalla died with a severe Paecilomyces infection, whereas this mangrove monitor with a really distinctive mycotic dermatitis, well-circumscribed lesions, actually had succumbed to a mucor infection. The bottom line is, whenever you see a crust on the skin of a reptile, you must do not only fungal culture, but also put on a PAS or a silver stain to find those organisms. Sometimes, if you're lucky, you may just be able to flip out your condenser and see the ghost-like remnants of those fungal elements in that crust, but please be sure to always do that. But most important of all, whenever you see a fungal infection in a reptile, is that you must address the management changes, because all of these infections have been associated with excessive humidity, crowding, malnutrition, low environmental temperature. Remember, these are cold-blooded animals. Their immune response is related to their external temperature. If we're keeping them chronically at an improper ambient temperature, they will never be able to mount the proper immune response to any of the pathogens we're discussing. Okay, skin. A number of tumors have been reported in the skin of snakes, fibrosarcomas, melanomas. But in addition to that, we need to remember those different chromatophores that we were discussing, those normal pigment cells, the iridophores, the xanthophores, the erythrophores, because tumors have been described in all four classes, and we assign a general name to them. We call them chromatophoromas. And we're going to look at one last slide, and then we're going to be changing our carousel. When we see a heavily pigmented mass like this, I caution you not to ever automatically assume that we're dealing with a malignant melanoma. If you would have done EM on that pigmented mass that looked very much like a melanoma, instead of seeing the usual pre-melanosomes and melanosomes and varying stages of development, instead we end up with something like this, which is a latticework of empty spaces. Now, this is not artifact. In fact, what we're looking at is an iridophoroma, because the pigment cells, the crystals that have now dissolved out with the routine processing of EM. So they were there, but they're gone now. But the fact that we're seeing this lattice work really is diagnostic. Now, obviously, you're not going to be doing ultrastructure on every biopsy that comes your way if you're doing work for some local zoo. But there is there is a light microscopic feature that can help you make this diagnosis. First of all, remember the pigment can have an olive green tinge. It may not be just dark brownish black. But also, if you see this pigment, just put your polarizer on. This pigment will, it's birefringent. And it's quite pretty under the scope. Chromatophoromas have been reported in a number of species of snakes, although I suspect it's greatly underreported because I think a lot of people would simply assume these are malignant melanomas. As far as we can tell, they do behave, even though we have very few reports, they do have malignant potential with local recurrence, and it is an important diagnosis. Okay, let's move on to bacterial skin disease. There's a non-specific entity referred to as blister disease. It's included under this bacterial section because many people believe it's due to a Staph aureus infection and that it's a primary infection. However, other people are of the school of thought believing that the staph is a secondary invader, so I think it's still up in the air. Basically, these snakes will develop a severe vesicular dermatitis clinically and will often die due to inanition and septicemia. The thing we need to remember when we see this is that it's associated with a continuously damp environment. Okay, I'm looking at this section of skin. I see some big mass lesion here, and gee, on high power, this looks like a squamous cell carcinoma, doesn't it? I mean, we've got the nice epithelial cells, and we've got keratin pearl formation in the center. Well, no, this isn't a tumor. Don't fall into that trap of assuming that just because it looks something like what you'd see in a dog or a different domestic animal species, this is in fact a mycobacterial abscess. And so it's got to be way up there on your list of differentials whenever you're dealing with skin lesions. Look at this list: fungal, lots of different parasites, neoplasia, bacterial. So procedures when you're working on skin, you're going to want to maybe save some of those parasites in 70% alcohol for future identification. If you're doing a biopsy or cytology, don't forget to do those acid-fast stains, do a gram stain, do a PAS stain. Do your fungal and bacterial cultures, and remember that one filarid nematode that caused that pustular dermatitis. Let's not forget to do hematology and check for circulating microfilaria. That might be an aid to diagnosis. One last thing, don't forget, we also have to consider genetic or developmental categories of diseases. In this case, this Texas rat snake was completely smooth. He had no scales whatsoever, and he also had a number of other defects. All right, when you've completed your external exam, you place your snake in dorsal recumbency, and you're going to make an incision. I like to start down by the cloaca, and I'm going to reflect the skin all the way up to the intermandibular space. Bear in mind, these directions are only for non-venomous snakes. I don't think you should be working on venomous snakes. I don't think your client should have venomous snakes unless they're in a zoo setting. I just don't think you should be taking any chances. When I work on very dangerous snakes, we request that the heads are taped so the mouth is not going to cause any problems, and we only go as far forward as the thyroid, and then we proceed with extreme caution. As you're reflecting the skin, you're going to see the abundant fat stores in the body. In fact, most of the organs are going to be obscured by that. All right, here we've gone all the way up to the intermandibular space. As you've opened the snake, you've also noticed that they lack a diaphragm. They have a single pleuroperitoneal or coelomic cavity. This is very important implications for lung problems that we'll see later. I basically remove all of this fat tissue because I'm not going to be able to see much until I've dissected it off, and then I want to look at my viscera in situ. Snakes have a single thyroid. It's anterior to the heart. And as you can see right here, very easy to find, but again, just as we mentioned, tiny little spleens in amphibians, tiny little thyroids in snakes, I always harvest those immediately, put them in a cassette so I won't lose them for histologic evaluation. There is some thyroid pathology described in snakes, although it's really far more common in tortoises, and as you can see, this is a snake with a massively enlarged thyroid or a goiter. The parathyroids can be difficult to find, and they're buried really in the thymic tissue. They do have thymic lobes, and you can see right here. The lung tissue, we'll get into in a moment. The heart, which we're looking at right now, is again one of those sinusoidal trabecular hearts, very primitive hearts. If you're dealing with a live snake, you can see the heartbeat on the ventral surface of the snake. And the lung tissue. Now this is where things really get a little bizarre. Most snakes have only one lung, the right lung, but there are always these exceptions. The pythons and boas will retain the left lung to variable degrees, but in most species the left lung is vestigial. The gas exchange occurs in the proximal portion of the lung, which will have a prominent reticular pattern, which you can appreciate. As you move further caudally in the snake, that lung turns into a highly transparent air sac. And here's the lung, which follows all the way along the length of the liver. And here we're back to that air sac portion. I like to evaluate this before I do anything else because once I strip out the viscera, it's difficult. You lose that air sac portion, and it's more difficult to evaluate it. Okay, the liver is a large elongated organ. The stomach is elongate and spindle shaped, and you want to get a feel for the normal size of a snake stomach because it's a very important disease problem we'll be addressing in a few moments. The small intestines are highly coiled and adhered with a very thick mesenteric attachments, which you're going to have to break down. You can't simply run the intestines with a scissor as you would with other species. They do have a large gallbladder, and this can be located at varying distances from the liver because they have a very long, here's the liver, here's the cystic duct. So don't be surprised to find the gallbladder at some distance from the liver. Snakes have a fused splenopancreas. Again, there can be some species variation, but here we have a beautiful example with the pale pancreatic tissue and the dark red splenic tissue. And if you're just getting into this, or maybe you're doing a lot of work for your local zoo, I recommend you stop and consider sampling some of these unusual histologic features, putting them in a little independent cassette, labeling the side of the cassette, so when you get the slide it'll say splenopancreas, make an extra recut, and it's a very nice way to build up an in-house glass slide comparative pathology teaching set. So for your students or residents or whatever, it doesn't take that much time, and it's a good thing to do. And there you are with your beautiful example. The spleen is on the left and the pancreatic exocrine tissue is on the right. The kidneys of snakes are also interesting. They're very pretty. They look like a stack of pennies. The right end kidney is anterior to the left. The adrenal tissue is caudomedial to the